Okay, now that we have everything labeled for our ECoG, I'm actually going to make it even a little bit bigger here just so we can see it a bit more clearly. You don't want to artificially inflate the amplitude of these, but we do want to make sure we're seeing everything correctly. So again, we've got our baseline here at the lowest point. This is a better latency. I like it to be a little further away from 0.5, whereas this one on the left side is right at about 0.5 milliseconds. We'll see our SP and then AP1, AP peak, and AP2. So what do all these mean when we're making calculations? When we're looking at an ECoG, there's really two things that we're going to analyze. The most common thing is going to be your SP-AP amplitude ratio. Your SP-AP amplitude ratio is really the ratio of how tall the SP is compared to how tall the AP is. And that's relative to baseline. So if I've got my baseline here, then how tall the SP is from that point. So it measures or calculates how tall it is from the baseline to where my SP is. And then it's going to measure the baseline all the way to my AP peak. So I actually don't need the AP1 or the AP2 values for this SP-AP amplitude ratio. I only need the baseline, the SP, and the AP peak. And that will calculate this ratio that we see over here on the left, this SP-AP amplitude ratio we'll see right here. And for this patient on the right side, it's 0.421. And if I double click on the left, we see 0.057. Now we can see a pretty big difference here, which is nice to see. This left one, it's very short between the baseline and the SP compared to the best baseline to the AP. So because there's a bigger difference between those two, this ratio is going to be much smaller. We want there to be a big difference. The closer they are together, the higher this value gets, which we see on the right side because the SP is much higher in relation to the AP in terms of how tall the peak is. And remember, this is a negative deflection, so we're talking about height, but it's kind of depth almost in the way that we're looking at it here when it's flipped. And so this is more concerning than the other just because it's higher, but a lot of research shows that we're looking anywhere between 0.4 to 0.5. We want it to be less than those values, so that rules out the possibility of Meniere's. I say this with caution because if a patient is not actively having a Meniere's attack, then this still might be normal. So this is a test that's helpful, but also has some limitations as well. The second thing to look at is our SP-AP area ratio, which we also see over here off to the left. Usually I've seen several different numbers for this, but normal is going to be 1.8-ish or less. And so this one's really good here. If I swap over to the left side, we're also seeing that it's pretty low. And this has to do with the shaded in region. So it's shading in the sections between all of this here versus this part here, and so it's taking this cross-section overlap to see how large was the area of that section, and it's giving a calculation based off of that. And so we'll see, you know, we've got a pretty large area here compared to this one here, and so it's calculating the area that's shaded in that space. And so that's how that calculation is made. Again, there's a lot more math to that, but just kind of the simple version of what we're looking at. And this is normal for both ears for both of these patients that we're seeing.